Good evening, everybody, and welcome all of you to the live program number 126 at Orthopaedic Principles. We are back with our amazing faculty, Dr. Krishna, Kiran, Eachampatti from Medical Hospital, Hyderabad. If you have noticed, Dr. Krishna has earlier lectured with us 3 times, and today it's his fourth lecture. Dr. Krishna is interested in primary, complex, and revision arthroplasty, and he's also an alumni of the All India Institute of Medical Sciences, New Delhi. Today, Dr. Krishna is going to enlighten us on the classification and management of femoral bone loss in arthroplasty. Over to you, Krishna.
Thank you, Hitesh. Thanks for having me. So we'll be looking at classification and management of femoral bone loss in revision hip arthroplasty. So now the basic principles for femoral revision, we've already done the acetabular side, include rotational implant stability, rigid implant fixation over long period of time to achieve stable hip joint with good range of motion, to restore the femoral integrity and continuity wherever there is a fracture type of situation. And we have to prevent further bone loss and augment the existing bone loss. And of course, restore the biomechanics, that the leg length and offset. So why is there bone loss in revision surgery? So it can be because of aseptic loosening. The patient is continuing to walk on a loose implant. It could be because of infection. It could be because of polyethylene wear and the wear-induced osteolysis. You could have certain implants like the fully porous coated stems, which can lead to stress shielding over a longer period of use and bone resorption of the unloaded area. And of course, you can have bone loss, which is unintended during removal of well-fixed implants. We have several classifications for the bone loss. Like any procedure, we must classify it before we embark on managing these difficult situations. And it is essential in order to do a proper preoperative planning and implant selection. And we must also have a common language for reporting surgical results. So that is why a common bone loss classification is essential in order to deal with these complex problems. Now we have the American Academy of Orthopedic Surgeon classification system for femoral deficiencies. They classified them into segmental, cavitary, combined, malalignment, where there is a varus or valgus malalignment of the femur, stenosis, and discontinuity. So this is a reasonable classification system, but the one which we normally use, as always, is the Paprosky classification system. So he has classified the bone loss into 4 types. The type 1 bone loss is where the proximal and distal part of the femur, that is the meta and diaphyseal area, is largely intact. There is minor cancellous bone loss, which is happening in the proximal part of the femur. So it's a sort of a cavitary bone deficiency of the American Academy of Orthopedic Surgeons. In type 2, the metaphyseal corticocancellous bone is largely gone, but the diaphysis is intact. You can see the X-ray there, where the calcar is more or less resorbed and then the stem has sunk inside. So you have a metaphyseal bone loss, but the diaphysis is largely intact for fixation of a revision implant. In type 3A, the diaphysis is partially supportive. So the metaphysis is completely gone, but more than 4 centimeter of isthmus is intact for fixation. So all these classifications beforehand help us to choose the preoperative implant. So we must have one implant which we deem appropriate for the revision, one at a higher level and one at a lower level. And we must choose the implant with the least amount of violation of the femoral canal. And we'll come to the implant selection as we go in. So if we have 4 centimeters or more of isthmus, you can have a diaphyseal scratch fit achieved. And that is what we will choose to do. In type 3B defects, the diaphysis is non-supportive, as there is less than 4 centimeter of isthmus intact for fixation. So this is a 3B defect where metaphysis is gone and the diaphysis is partially supportive. So you need to have the bone there in the proximal femur and diaphysis in order to get a reliable bone ingrowth which will last for a long period of time, and also lead to loading of the bone proximally where it is deficient, so that there is reformation of the bone in the long run. In type 4, both metaphysis and diaphysis are non-supportive and no part of isthmus is available for fixation. So these are really challenging cases and require innovative methods of dealing with such issues. Now, the problems in revision, the proximal bone is typically deficient, as we saw, cannot support stems that rely on proximal fit and fill. So, one mistake I see time and again done by the younger surgeons when they're doing an AMP revision or a bipolar revision is to use an on-growth type of stem like the corel, which is a proximal tapered wedge stems. They don't work in this situation. What happens with these stems is they achieve diaphyseal fit, and that is when they will fail. So whenever the proximal bone is deficient, we must not rely on proximal fit and fill stems. The only proximal stem which we can still use is a modular stem, where like the stem in sleeve construct, where you can use an SROM type of sleeve, especially in the type 1 and 2 types of defects, where we want to do a proximal loading fixation, especially in a young patient, but it must be a modular stem. We cannot use a tapered wedge type of device in these cases. So the failure of the proximal fixation devices to help in these situations has led to the development of diaphyseal engaging stems. So these load the diaphysis and bypass the deficient proximal femur. The typical principle is at least 2 cortical diameters distal to the area of bone loss or the screw hole or whatever is the proximal deficiency. So now the monoblock extensively porous coated stems have been the cornerstone and workhorse for managing revision surgery for a long period of time. And these have now largely been replaced by the monoblock fluted tapered stems. And I will tell you why there is a change in the use of these stems. And we also have the modular fluted tapered stems. So these are the 3 basic workhorses for managing all sorts of femoral revision procedures. There are other issues as well, like expansion of the cortices, varus remodeling, in which case you may have to do a corrective extended trochanteric osteotomy in order to correct that varus remodeling. You can have varying levels of leg length discrepancy because of the previous implant failure, and instability is always a concern because of our inability to restore the leg length and offset to the pre-arthritic levels. Strategies for managing femoral revision, as I told you, we must go in a sequential way with the most conservative option being used. So you must use a conservative revision wherever possible. So look at a conservative revision stem like a long corel or the modular SROM type of device when the bone loss is of lower grades. This progresses to with one which is largely the workhorse for my own revision practice, which is the Wagner device, which is available in 190, 225, 265, and 305 millimeter lengths. And it's a monoblock grit blasted stem with flutes which are available distally. And this has got version control which is possible, and it's a diaphyseal engaging stem. And we must use the shortest possible length which gives us stability. A long stem does not necessarily give you more stability because of bowing of the femur. So if you have a scratch fit of 3 to 4 centimeters on a shorter stem, that is better than using a longer stem. Now, certain situations do warrant, and certain surgeons, because of their familiarity, continue to use the cobalt chrome porous coated device, which is stood the test of time, but it has got its set of issues. Now you have the modular mid-stem modularity. The first one was a stem in sleeve modularity, where the stem goes through the sleeve. The mid-stem modularity is where there is a distal part and a proximal part. The advantages proposed for this are that you can independently size the distal and proximal parts of the femur, as there is a likelihood of mismatch. And if you just size distally and leave the proximal part, sometimes it can break at the junction of where there is fixation and no fixation. So the advantages are you will be able to tailor the leg length and offset to that particular patient. You will be able to mix and match the proximal and distal diameters, so you can get independent distal fixation and independent proximal fixation, uh, irrespective of the size of the proximal part of the femur. The only problem with this device is if you don't have adequate proximal support and ingrowth, which happens over a period of time, the corrosion and fretting at the interface between the distal and proximal parts can lead to a fracture of these modular stems. So we don't prefer to use the modular stems in our own practice. Now the modular stems or the non-modular stems have got this interlocking option, and we have certain devices which are still available with this interlocking ability. And the first concept was from the Bicontact team, the Professor Weller group, which came out with the bicontact interlocking stem where there was only proximal fixation. So they created a transfemoral approach, used a proximally loading stem, which was interlocked for primary stability. And then later on, because of bony ingrowth proximally, it became a proximally loading device. So that was at least in theory what they said. The last option is a tumor prosthesis. So this is the algorithm for managing the femoral revision situation. Now, by and large, if you look at the femoral classification based on bone loss, the type 1, 2 are amenable to conservative revision. Type 3A and 3B are ones where we transition from a monoblock device to a modular device. And type 4, Kumar, you're looking at a allograft prosthesis composite, a modular device, or a tumor prosthesis. So that's in depth the summary of what we are going to see as we go on. So before we go to the formal femoral revision, there is a subcategory where the cement mantle looks reasonably good. So this is a aseptic loosening on the acetabular side with a reasonably well cemented collarless polished tapered stem. So you can see that the cement bone interface is largely intact and there is adequate cement mantle. So you don't need to remove this entire cement and do a big revision in this 80-year-old patient. So what we did was what we call as a cement in cement revision. So you just do the acetabular revision, knock the stem out because it's a collarless, polished, tapered stem. There is no bonding between the stem and the cement mantle. The entire load is on the cement mantle bone interface. And then you use one size smaller stem to re-cement, which is called as a cement in cement revision. Or you can use the same stem if the trunnion is not damaged, which is called in cement revision technique. Another example where because of the protrusio, we had to do a transtrochanteric type of approach in this case. However, the cement mantle is very good and a 64-year-old man taking all that cement out would be too much of a challenge. So we were just able to get away using a cement in cement revision. So this technique does work well. So if there is a good cement mantle in place, one must definitely consider the role of cement in cement revision, especially in conjunction with the collarless polished taper device. Now we look at different situations. Now here the metaphysis and diaphysis is largely intact and you just have some minor cancellous bone loss in the proximal femur. So this is a damaged metaphysis, but it is a Paprosky grade 1 because the metaphysis is largely intact. But what we don't want to be doing here is putting in tapered wedge stems. So the options here, of course, it's better classified by the AAOS classification, which is a cavitary classification. So these are all the surgical strategies which are possible. So you can do impaction bone grafting with a cemented stem if you are good at it and it's a young patient. You can do a modular sleeve with distal non-fixing stems. It's a modular proximally loading type of fixation. You can do a tapered long stem. Typically in our hands, it's a non-modular monoblock device or a fully porous coated long stem. So for me, in a Paprosky grade 1, the options 1 and 2 work well. So I would either do an impaction grafting with cemented stem, or more often I would do a modular sleeve with a distal non-fixing stem. So that is what was done. So it still is a proximally fixing device now. So the sleeve will integrate. Distal part is not going to integrate. So it will proximally load, and over a period of time, as you have seen, there is reconstitution of bone proximally, and this patient will have a good outcome. Now, another example where you have damaged metaphysis, but the diaphysis is intact. More than 4 centimeter of isthmus is available. It's a Paprosky grade 2. So again, here you have several options. You can do a cemented long stem, which is not our choice. I would not do a cement in cement revision in this case because there has been a subsidence of the stem, which indicates that the cement mantle is defective. Modular proximal fixation is an option if you are able to remove all that cement without causing much bone loss and have adequate proximal bone for fixation. You can use a long tapered stem or a fully porous coated long stem. So that is the options for a Paprosky 2. So a case example, you can see this is an infected hip in a very young patient, which was managed with a cement spacer and subsequently revised using a modular proximally loading type of device. So this is our go to. And you should notice here that this patient also had a femur fracture which had malunited. So there was no way we were going to put in a long stem in this patient by bypassing that thing without having to break it. So another important point here is not go with the short leg film, should always do a long leg film, also a lateral view to look at the bowing of the femur for all your femoral revision patients. So I just wanted to illustrate that point as we go along. So another example of a type 2 defect managed with a distally fixing porous coated device. So this was done way back 10, 12 years back. So those days we were using the highly porous coated stems for the revision surgeries. We don't use it anymore. Now you have the type 3A defects. You can also see that there is an angulation there, varus remodeling. And the type 3A defect is where there is proximal bone loss in the metaphysis, but 4 centimeters or more of isthmus is available for fixation. So the choices here, you must consider the role of an extended trochanteric osteotomy if you are not able to get your stem distally inside. That will also facilitate the removal of bone cement. But if you're able to get your stem inside in a proper way without having to do an osteotomy, up to 10 degrees of angulation can be accepted. But beyond 10, you will definitely have to do ETO. Cemented stem, modular stem, not options in these cases because the proximal bone is already damaged. So there's no way you'll get fixation of the sleeve. The only options here are either modular or non-modular tapered stem or a long, fully porous coated stem. So this is the rationale of thought process. You should look at your preoperative X-ray, look at what is the bone available for fixation, look at the length where you need fixation. You must pre-plan the length of the stem available and see and plan your implant removal strategies. So that's the post-operative X-ray. So we didn't have to do an ETO in this case, but we were prepared to do an ETO. But intraoperatively, we found that we were able to get away by using a modular titanium stem. One advantage of the modular titanium stem over the porous cobalt chrome stem is that if there is proximal part of the stem which is not having bony contact, the cobalt chrome stems can fracture at that metaphyseal diaphyseal junction. So it's always a better idea to put a titanium stem like a Wagner in these situations. Another example of a 3A defect, you can see that the proximal part is almost damaged. Again, reconstructed using a Wagner type of device. 4 centimeters of scratch fit distal to the bone defect is what we want. And 4 centimeter of isthmus was available in this case for fixation. Now coming to the Paprosky 3B classification, here we're dwelling into more complex situations. The proximal part and the upper diaphyseal part or the isthmus part is damaged. Less than 4 centimeter of isthmus is now available for fixation, and you will have to classify this as a Paprosky 3B. Surgical strategy, cemented and modular stems are out. Options, modular or non-modular tapered stems. So you're tending towards the use of modular tapered stems in these cases if you go with what is recommended. But because of the risk of fracture at the modular taper interface, we tend to use a non-modular tapered stem like Wagner or a long fully porous coated stem in these situations as well. In a young patient, one must consider bone augmentation either through cortical strut grafts or the use of a proximal femoral allograft. And these are interesting cases where we can consider an interlocking stem. So these cases, if we are using a modular tapered stem where the proximal and distal parts are separate from each other, it's a good idea to use cortical allograft on top of the defect area and use a plate to support this particular allograft to offload that modular taper junction. So the first case was managed using a fully porous coated stem. As you can see, the length of the stem keeps increasing. As it goes beyond 200 millimeter, you will have to use board stems in order to get through the anterior bowing of the femur. An ETO was done to correct the angulation in the first case. In the second case, we were able to get away using a more recent case. We were able to get away using what is our workhorse, the Wagner stem, which is a titanium monoblock grit blasted stem with lot of anti-rotation fins which are there to get fixation. Now the type 4 Paprosky, where metaphysis and diaphysis both are deficient, are even more difficult to deal with. These definitely require either an interlocking stem or a modular stem or a combination of both. And some situations may also require a tumor processes like a situation. The other option is a proximal femoral allograft composite. So you use a proximal femoral allograft to reconstruct the proximal femur and use a distally locked a stem or a solution type of stem. Then you have a proximal femoral replacement, and you're also getting into the territory of a total femur prosthesis. Now you can see this particular case was came to us with a solution stem in place, which is already a porous coated stem, and this patient had been treated with a subtrochanteric osteotomy, and there was contact between the cobalt chrome of the implant with these screws, which probably were titanium screws. And as you can see, there was a lot of metallosis related damage to the proximal femur, and this implant had become loose, and the entire proximal femur had been eaten away. So now this was an ideal case if it were a young patient for a proximal femoral allograft or the use of a modular stem. And as I told you, I have a little bit of reservation using modular devices, especially the mid-stem modularity. So we use a 305 monoblock Wagner to reconstruct it. You can see that there is around 6 to 7 centimeter distal thing. And it has been a consistent observation in our practice that with time, the proximal bone reforms with this device. And unlike the solution stem, which can break, this doesn't break. And that's what is happening. That's 3 to 4 months down the line. You can see that the medial bone is reforming. And this patient is a year out now, and is able to walk quite well. And I don't have the latest X-ray, but it is showing a hint of lateral bone reformation as well. So the tube reconstitutes itself once the bone loads in a particular way. Now, we must also factor in anticipated intraoperative bone loss, which alters your assessment of the bone defect. So, although looking at the preoperative X-ray for this particular case, it appears that it is a Paprosky 3A with isthmus intact. Once you remove this particular implant through a transfemoral approach, nothing much will remain, and you will need to use an interlocking modular stem like the reef or the modular devices, and there is no choice but to use this sort of a device in these particular cases. Of course, if the proximal femur and diaphysis are deficient, like in this particular case, you will have to use a tumor processes, and there is no other way. There are certain limitations to the Paprosky classification. You have intra-observer reliability issues. It does not factor in the intraoperative bone loss, and it is not applicable for all revision situations encountered. So certain situations are beyond this Paprosky thing. So now you have situations like this with a broken AML stem with high levels of cobalt chrome levels, which requires removal of this particular implant. And as I spoke about this in the implant removal section, these are difficult stems to remove. And now we've become better at it. As you can see, we had revised the left one around five years back, and they used a 265 Wagner because of difficulty in removing it, and along with a TM augment for acetabulum. On the right side, we did it 2 years back for increasing cobalt levels. And you can see that we've become better at revising it. We were able to remove it through an ETO, and we're able to get away with a 225 stem. No need for augment on the acetabulum side. Older, you get wiser, you get better with your surgical technique, you get more patient, and are able to deal with the situation. So the situation on the right is much better than the left, because now we have an option of putting 265 whenever we have to revise the right side, but we now have to go for 305 if we have to revise the left side. So we need to not burn our bridges whenever we do a revision. It's easy to do a total femur prosthesis, but we must do the most conservative revision possible for that particular patient using the shortest length of implant, which is stable and has potential for long-term biologic ingrowth. So that is the principle. You can have situations where there is a periprosthetic fracture. Again, these will entail some levels of bone loss, and these are best managed either with a modular long stem, which will allow us proximal loading and bone reconstitution over the long period of time, or In certain situations where the proximal bone is damaged, you may have to do a Wagner type of device for these as well. But as you can see, these two are our go-to devices, the modular SROM with long stem or the monoblock Wagner type of device. These are our revision mainstays. Lastly, we come to these broken implants. So why I told that we should not use the cobalt chrome fully porous stems if there is no proximal bone support, is because this particular case I only operated 7 or 8 years back, and you can see that it's come back now with a fracture of the metadiaphyseal junction. So wherever there is no bone ingrowth or there is no proximal bone support which has formed, despite our best efforts, the distal part gets fixed into the bone and the proximal doesn't get fixed. And somehow with these cobalt chrome stems, we have found that they tend to break over 7 to 10 year period, especially in fat people, male patients who are very, very active. So this patient we had to revise. There's no choice in these patients but to do a transfemoral approach, and the revision can become a little bit of messy. But with the use of a monoblock Wagner, we are able to salvage even this difficult situation with a 265 stem. So we still have a 305 option available for this patient as and when he comes back for a subsequent revision. He's only 55 years old. Certain situations, the femur is non-supportive for uncemented fixation. So these are very osteoporotic, not uncommon in our country. It's very difficult to put a number on the Paprosky for this, maybe a grade 4. But there is some role of a impaction grafting or a long cemented stem in only such situations. So by and large, we tend to avoid cemented revisions unless it's a cement in cement or an in cement revision in a well fixed cement mantle in femoral revision situations. So this is the algorithm: cement in cement revision, retain the proximal bone, try and load the proximal metaphysis in the lower grades of bone loss, 1 and 2 Paprosky. The monoblock Wagner type of device, if not possible, use a porous coated stem. If you're familiar with it, we don't tend to use it that frequently. Modular stems with or without interlocking, that's the next line of progression. Tumor prosthesis and total femur are the final situation for femoral salvage in revision hip arthroplasty. So we should not forget this sequence: cement in cement or in cement, proximally loading modular stems, stem in sleeve constructs like SROM, the use of a monoblock Wagner stem, which is the workhorse for revisions in our hands. There is some role of porous coated as a salvage option in elderly people, or if you're more familiar using that. The use of either interlocked or non-interlocked modular stems, the proximal femoral replacement processes. So take home message: ability to identify and predict bone loss is important. Use 2 classification systems and get familiar with them, the AAOS and Paprosky, which apply in most situations. Whenever you're revising, get your assistant or fellow, whoever, look at the X-ray, you look at the X-ray, write down the classification, do the surgery, find what is there intraoperatively, write it down again, see what is your inter and intra-observer reliability assessment, make proper plans and execute them. Please choose a revision option which leaves bridges open for future. Have 1 level higher implant available during surgery and try for 1 level lower wherever possible. Thank you.
Thank you, Krishna, for another excellent presentation. A few questions.
Yeah.
What is the difference between a porous coat and a grid blasted fixation with respect to the design and also in this particular scenario?
The porous coated stems are cobalt chrome stems. So there is a coating on top of that, which is either a tantalum coating or whatever. There is ingrowth into this particular porous coated device. So most of the porous coated are cobalt chrome devices with sintered bead coating on top of that, or a porous coating on top of that. The grid blasted are more of an on-growth type of device. The ones which we talked about previously, the Zweimuller stem, the Wagner stem. So they are not highly porous in surface. So there is no ingrowth into these stems, but there is on-growth onto the stems. And they've got anti-rotation fins for getting diaphyseal scratch fit and fixation. So it will not rotate. At the same time, because there is on growth, the remaining part of the proximal bone is also loaded over a period of time. So what we have observed is with the cobalt chrome fully porous coated devices, there is ingrowth distally, diaphyseal fixation, proximal parts disappear over a period of time because of stress shielding. On growth devices, the grid blasted devices, there is loading of the proximal bone as well because there is on growth, there is no ingrowth here. So the bone reconstitution and reformation over a period of time happens. So completely different philosophies. The second thing is these are made of titanium, so they don't break as easily. That's what has been our observation. So even if you didn't have the proximal metaphyseal or metadiaphyseal area ingrowth or on growth happening, it will not break at that junction. So I have not seen any Wagner stems break, but I've seen quite a few of the solution stems break. The cobalt chrome devices tend to be sensitive to this sort of a loading mismatch. So if you have distal fixation, no proximal ingrowth, wherever there is that transition zone, it will break there.
So in that case, the long-term data of a grid blasted fixation like a Wagner should be much better than a porous coated one, isn't it?
The long-term data of grid blasted is pretty good. It's not bad at all. But the by and large, the with the Charlie Yang Anderson Institute coming out with the solution stem, most of the world were using the fully porous coated devices. Although Wagner himself was using in 1960s, 69, I think was the first publication on Wagner revision stem. The European groups tended to use the Wagner more often than the US group. So US was more driven by the porous coated thing. So all companies were the salt came up with porous coated implants. I have nothing against them, but I tend to find the Wagner is a much more once you learn how to use it, much more versatile option and more forgiving than the cobalt chrome devices.
Yeah, of course, when you say that there's a risk of higher proximal femoral bone loss, and also when in the transition there's a risk of breakage, and that does not occur in a Wagner stem, of course, that's going to be a huge advantage, isn't it?
Yeah, the only disadvantage with Wagner in the published literature is that there is a 20% rate of subsidence, and that I think is a technical error. So if you don't do the operation well, the Wagner will subside. So what we do is we tend to get our offset right first. So we will suppose we want to size the Wagner, we will get our offset sorted out first, and then keep on upsizing till we are not able to go further in to the distal diaphysis. That's the way to do the Wagner. So you have it starts from 14, the distal diameter is 9, so 15 is 10, like that you have different options. So it's a tapered 3-degree taper which goes from top to bottom. So you choose whatever is relatively reasonably stable. 16 is stable, you do a trial with 16, set your offset options right in the hip, and then keep on upsizing the implant till you get no further distal migration. So we've not seen any subsidence in our series. We've done more than 100 of these Wagner stems, and they don't subside if you do a proper surgical technique. So that's what. So why people are afraid to use it or they don't use it as often as it should be, because published literature shows 15 to 20% subsidence rate with the Wagner type of devices. That's because they have undersized them, and then also the concept of putting a long stem, that is wrong. You should not put a long stem. A 190 stem which is thicker is more stable than a 225 or a 265 stem which is thinner in diameter, because the longer stem tends to get a 3-point fixation. It's not going to get diaphyseal scratch fit. The shorter the stem, more is the chance for it to engage the diaphysis. So you must aim for a shorter length of stem, at least 4 centimeters bypass, but it must have a good diaphyseal fit. So that's a common mistake which is made. Yeah.
I think the whole philosophy, like you said, is a concept, isn't it?
It's the concept. You have to understand the concept and execute it properly.
And see, when you say there is a risk of subsidence in the published literature, of course, it doesn't happen in your hands. So what happens if there is subsidence? What is going to be the outcome?
So if there is subsidence, there can be instability. So the other issue with Wagner was the neck shaft angle and the higher risk of instability with the Wagner, again in published literature. If you have a subsidence in revision scenario, then two things can happen. One, it can become unstable. Two, you can lose fixation as well over a period of time and become loose as well. So it's absolutely critical to follow the correct surgical technique to get a good fixation on table. So on table, if you have a good sizing, it is not going to subside.
The other one is the stem sleeve construct that you mentioned about the SROM. Now, is SROM a porous coated device?
It is a porous coated device, but it is going to have only proximal ingrowth. And the distal part is just not coated. It will just have fluted, it's a fluted type of rod with grooves. So it will have rotational stability and it will taper lock into that sleeve. So you have two advantages. One, you're going to load the proximal bone because it's going to ingrow there, and there is going to be reconstitution of bone over a period of time. And you have not violated the diaphysis, which can be used for a future diaphyseal fixing stem, or you can just exchange the stem. So the modular part can be exchanged. Once the sleeve is well ingrown, you can just put in a new stem into the construct at the time of revision. So you have a potential for 20-30 years of proximally fixing thing. Once that fails, then you can look at a diaphyseal option, and you can retrieve it with a short trochanteric osteotomy or even without an ETO.
Now, Krishna, your lectures have been well received by the audience, but there are several of questions that have come to me. See, some of the audience, they want to know what is the fundamental difference between the Chandli philosophy and the Muller philosophy. Of course, Wagner is a stem design, but Chandli and Muller is a concept, isn't it?
The Chandli Muller are by and large similar concepts. They're all composite beam philosophies where the implant will act like a composite beam, like a pillar, so you have a loading from the top and it will move along with the femur. The second is the taper slip philosophy. That's the Exeter group's philosophy, where you have a collarless polished taper. So there is a taper which goes from superior to inferior, medial to lateral, and anterior to posterior. So this is called triple taper now. So original Exeter was a double taper. Now it's become a triple taper with the C stem and some of the CPT designs. So where it tapers from medial to lateral, anterior to posterior, and superior to inferior as well. So the concept for the composite beam is the entire thing will be loading. So the proximal part is not loading. The stem itself is got some bonding with the cement bone interface. So whenever the composite beam fails, it will fail by varus collapse, and there will be some level element of stress shielding proximally as well. In a taper slip philosophy, whenever there is loading, there is compressive loading of the cement bone interface. So because the stem doesn't actually interdigitate with the cement, it's collarless and polished, there is a potential for controlled subsidence of that stem into the cement mantle. Not too much, but a few millimeter. So all the stress is a compressive stress. In a composite beam, it's a tensile stress or a tangential stress where the cement bone interface can get loose. But when there is compressive loading, the bone is loaded and the cement bone interface is protected. So the collarless polished taper, by and large, is now replaced the composite beam philosophy for the cemented stems.
Okay, so but the outcomes are generally better for a taper slip philosophy, isn't it?
That is right. Absolutely. So the composite beam was original Chandli. It's got excellent results. Make no mistake that at 40-45 years, still you have some Chandli cemented stems which have worked very well. And there have been a lot of variations in these philosophies as well, because if you look at the original Chandli, it was one type, and then they changed and the Exeter went to a composite beam philosophy, coated stems, and again went back to the collarless polished taper. So by and large, to make the confusion less for the younger audience, is the collarless polished taper or the taper slip philosophy, which is currently in vogue and works. It has got a protective effect on the bone because it loads the bone. It protects the cement mantle because there is compressive loading on the cement bone interface, and therefore the risk of loosening in the longer time is lesser. And it is also amenable for what we call as a cement in cement revision technique. So if the cement bone interface is good, you can replace it with another collarless polished tapered stem.
Thank you for that. So I agree with your philosophy that the taper slip has the best outcomes. So when you say about composite beam, the surface should be irregular, isn't it?
That's right. So the composite beam philosophy also combined with roughening of the stem, so that they wanted some fixation between the cement and stem. But these stems, when we revised, we found that the stem and the cement will all come out together loose because it's putting too much of shear stresses at the cement bone interface. So the taper slip is exact opposite of that. It doesn't want any fixation between the stem and the cement because it wants the load only to be taken by the cement bone interface and a compressive load at that, not shear stress.
And is there a difference between Chandli and Muller?
Both are similar. The Muller is just the Chanley is a curved type of stem. Muller has got a tapered wedge type of philosophy. So there is what we call as a French paradox, where they found that despite having poor mantles, if you have a very big, fully fitting stem with some cement thrown in, they tend to do equally well. So, but over a long period of time. So that's called French paradox. So it's exactly opposite to the taper slip philosophy. But the idea is this: if you don't want to load the proximal bone and retain it for a long-term revision, then it becomes an inferior fixation to a cementless. Right now, registry data says that cemented, cementless, there's no difference in fixation. So in a young patient as well, you can do a cemented stem, provided you do good cementing, use all the principles, use a collarless polished tapered stem, and do a proper job of the cementing.
Now, Krishna, you do a lot of unsubmitted stems, is it? So if you look at your practice, I think it should be 80% to 20, or
more than that. 99% will be unsubmitted.
unsubmitted.
1%.
Do you think there is a risk of periprosthetic fracture, higher risk of periprosthetic fracture with an unsubmitted stem? Because there is some level 1 data that says that the chance of having an intraoperative or a late periprosthetic fracture is going to be higher with an unsubmitted stem.
Definitely higher. The incidence is roughly around 2% for intraoperative fractures. Can go as high as 4% with certain stems. I have personally seen 4 or 5 patients who had perioperative fractures. Like it could have been an intraoperative fracture, but presented in the perioperative period with the thing. Usually, if we are using a tapered wedge type of design, like Ecorail or a accolade stem or something, it's a technical error. You make an error with the sizing of the femoral component. And if you're younger, you tend to be more aggressive with the broaching, want to go to the highest possible size, and then you fit the thing, and then that's when you cause intraoperative fracture. There's no doubt that is a possibility. But as you get better with the sizing part of it, and you know when to back off without fracturing, that is when the risk also comes down. But in my hands, I tend to find that the uncemented has got a more predictable workflow. It takes lesser time, and I'm able to give a more predictable outcome to my patient than a cemented stem. So if somebody can do a good cementing, I have nothing against that. But it takes much longer time for a cemented stem in a system which is not geared up to that. And it actually, there is not much of a cost difference, because you have 2 cement packets, you have cement gun, then the additional cost of time and all. So if the outcomes are similar, you would do a thing which is faster.
Okay, Krishna, I think that's all the questions that we have. Thank you for this another fantastic session. A lot of learning, great learning. Thank you very much for joining in, and we look forward for another one more from your side.
Sure, Hitesh. Thank you. Thanks for having me.
Thank you very much.